Thank you, Stefan. Thank you for that kind introduction, and thank you to the organisers. I must have done it all right last time because you've invited me back. And it's interesting that we've spent a day and a half discussing some very erudite science and clinical work. And I'm very pleased that the organisers have invited me to talk about this, because I think this topic brings into perspective what we as doctors should be doing. What's quality? Most of us, probably all of us, will need a doctor at some stage. And we'll need someone who's going to look after us and have our best interests at heart. And the quality of what we expect for ourselves and our family members, we want safety, we want effectiveness, and we want a decent patient experience. And what I'm going to do is take you through a series of issues where I think we've got a lot to learn about the science, but I think we've also got a lot to learn in how we behave. And I'm going to address 4 principal topics. You could say the last one's the most important, and we'll get to it eventually. We know from an awful lot of the studies that have been published, there is huge variation across Europe in particular with the way in which esophageal and gastric cancer outcomes are achieved. Sadly, those of us who work in Northern Europe, particularly the United Kingdom and Norway, have probably the worst outcomes. It's probably a reflection of epidemiology. We do have more diffuse type gastric cancer, for example. We do have the highest incidence of adenocarcinoma of the esophagus in Scotland. And if you're going to get this disease, your best place is to live in that nice part of the world in southern Italy. It also depends where you have your operation. This data from Holland shows that if you undergo your surgery in a hospital that's a university centre, you're likely to do better than if you were to undergo your surgery in a non-teaching environment, irrespective of the numbers involved. We've touched a bit upon the hospital volume outcome issue. This is some data we did from cancer registry data, retrospective analysis clearly showing that as you increase the number of resections from within an institution, not only did your operative mortality get better, so did your 12-month survival. The problem is, and we've just done this in the UK, looking at the data on numbers and trying to put a value on the total figure a centre should do, the actually only reliable type 1 data starts when you've done 20 resections. All the other data, such as this, is retrospective and is fraught with problems. So it's very difficult to put an actual figure on it when you're trying to work out what a centre should provide in terms of its service. We've touched a bit about waiting and watching with regard to esophageal squamous cell cancer. I'm going to show you a fair bit of data from the UK National Esophageal Gastric Cancer Audit. And those boxes with the whisker charts show the variation in the way in which therapeutic and definitive chemoradiotherapy is undertaken across the UK. Those are the various so-called cancer alliances, which is how the system is broken up in the UK. This variation across the country in regard to where you go will depend upon what treatment you get. So there's an inconsistency. And this is slightly worrying. The red line is the 60-day or median of 45 days from diagnosis to when your neoadjuvant treatment starts. Some poor individuals are waiting upwards of 80+ days before they start their treatment. And that begs a question about the way in which our services are put together. So there's significant variation in the way in which, in one country that's supposed to have centralized its services and supposed to have led on that approach, struggles to meet the sort of things we would expect as a patient. In order to try to address the variation, Cornelius van der Velde set up the EURECCA project under the auspices of both ESSO and ECHO a few years ago, starting out with colorectal, and we in esophagogastric were the second major cancer centre, on the thesis that if you can improve or reduce variation, you will improve your quality. And that's based upon audit, uniform data sets, best practice, and development of guidelines. All the sorts of things we know we would try and do. We've done a few projects. We've identified a core data set which everybody should be trying to record their data against. This involved looking at all the data sets that were done by the larger centres across Europe There were some places recording over 600 items. We narrowed it down to just 46 items, which are common across the respective registries and audits. We then looked at variations in the use of curative treatments, and then we looked at different service provision. One slide from the second study, which was looking at the use of treatments. This is neoadjuvant chemotherapy and chemoradiotherapy in esophageal gastric and stomach cancer. And you will see from the neoadjuvant chemotherapy, the UK has the largest use of it. We would, because of magic. Chemoradiotherapy for esophageal cancer was highest in Holland. You would, because of Cross. So there's these influences that make a difference to the way in which treatment occurs. There's also actually epidemiological issues here, because I haven't got the surgical slide for brevity's sake, but the number of distal gastrectomies done is greatest in France than it is in the other countries because of the nature of their disease. So these variations have to be borne in mind. We also looked by questionnaire, asking the major centres what their pathways were like, starting from diagnosis in primary family practice right the way through to the end of care. There are some similarities. The timing of diagnosis, the time to get to treatment, and the centralisation of esophageal surgery, not gastric surgery, at the time of the study in 2015, 2016, showed there were similarities. The one area there was similarity, our colleague from pathology, I'm not sure is here, so I liked yesterday, will be pleased to know that pathology is consistent across all of the countries. They nearly all report according to protocol. So we're getting the information from the pathology appropriately. However, there's significant variations, and to a certain extent we picked up on some of that as the last day and a half have gone through. Angela Riddell's presentation yesterday with regard to CT, the availability of PET CT is an issue in some countries across Europe. But it's the softer things where we are short. There are problems across Europe with the ability to provide the services of nurse specialists, that vital member of the team who's the patient advocate. We have significant deficits in the availability of nutritionists, dietitians. Most of our patients are dreadfully nutritionally depleted and they're not being looked after properly. MDTs, yes, we all think they're good things, but there's terrible variation in the frequency and the consistency with which they meet and discuss things. When I talked about this at a meeting last year, I was harangued by colleagues to say, you don't discuss everybody, do you? We do, because you may well miss some poor soul who's going to be denied an opportunity for a treatment because you think they fit into a box of palliative care. And we're also poor at research and audit. That's the only way interested parties like we have here are going to make the progress that stimulates them. There are some areas from that study where we can find improvements. The organisation, who sees the patient, how do they go through the process? What sort of practice? We can improve upon that. The uniformity of staging, the sorts of things I've touched on with regard to tumour board. There is no doubt that education is an issue. Most of the big cancer societies in Europe are desperately trying to do this to make sure that people can get trained appropriately, but also understand the role of audit. We are scientists at heart. We are in this room very focused on the research side of things, but there's no doubt we struggle. Some of it's funding, but it's making sure we're proposing or posing the right questions so we can get the necessary answers. And you don't spend 7 years completing a randomized controlled trial of 500 patients, because by the time you get there, the answer to your question's already been solved. And as I say, the softer things around the way in which we have nurse support, national guidance, MDTs, physiotherapy, etc., is a fundamental component. That's your variation. Now, what about the standards? Unfortunately, our colleague from Japan's gone home, but he would sit there thinking, well, we've told you what to do. You're just too stupid to do it. Their results, their standards have been revised over 60 years through the Japanese rules. And these have taught us how we ought to be doing it. And this algorithm in the most recent set of Japanese rules clearly takes us the whole spectrum across gastric cancer, from early stage disease with endoscopy right the way through to palliative care. We've tried. 2006 was signed. We did 2011, 2012 with S3 first time round. Oh, look, there's something there. St. Gallen, 2012. and ESMO, it's been updated. And we've probably come up with some agreed approaches in a general sense. I think we've more or less accepted in gastric cancer that D2 lymphadenectomy in the fit patients appropriate. And we've also recognized the differences between intestinal and diffuse types. So there's actually some uniformity in the way in which we do things. Fortunately for us, surgeons, the Japanese have given us some extremely useful information about how we should undertake the operation with regard to the nature of the extent of resection and the extent of lymphadenectomy, clearly demonstrating which nodal station should be removed, be it a subtotal or a total gastrectomy, depending on the nature of the disease at staging. So we've learnt and hopefully have got better. Have we? I think we have. Lizzie made reference to the fact that we're looking at this surgery at ST03 trial, the follow-on from MAGIC. It's still got problems with regard to R0. Only 3/4 get an R0. But it's this which I was pleased to see, that we've managed to get our UK surgeons working to protocol to get at least 50% of their cases having a radical lymphadenectomy. That's a standard that's to be aspired to. And part of the discussion we've got in that ST03 manuscript is to clearly demonstrate the improvement over the last 20 years through the D1, D2 trial, into MAGIC, and into here from the number of patients who are actually getting an appropriate operation as surgical guidelines dictate. What about oncology? Well, I think we've probably settled ourselves. You'll see I have only selected the word chemotherapy. I like to be a museum piece. Thank you, Lizzie, for showing the end of the road for MAGIC. But I think we now have worked out more or less which patients require appropriate systemic therapy. But despite the fact that MAGIC came from the UK, only half of the patients in the national audit from 2013-14 received neoadjuvant chemotherapy. Slightly disturbing when it was stated early on that neoadjuvant chemotherapy in gastric cancer is a standard of care. We've talked about guidelines. Do we need more? Sorry, Stefan. Sorry, Marcus. I know you're about to start doing it again. But do we need to set standards? And this is a piece of work that I would commend to you because I think it's beginning to show the direction of travel. It's an echo development on the back of large amounts of information to set essential requirements for quality care, to set the criteria that you need to get the best level of care, to then look at how the organisation of that care provision is undertaken, and then to measure the performance indicators to show you're actually doing it properly to the best ability that you can within your healthcare structure against your guidelines. And we've just completed this over the last 12 months. ECHO have produced 2 previously on colorectal and on sarcoma. We did this for OG. There's a melanoma one that's been done. It's about to come out as well. And prostate and breast are underway for this next few months. And essentially what we've done is looked at the individual components of both the essential members of the multidisciplinary team and those who are the so-called non-essential or non-core, but are vital to include that. And each of those areas have been asked to give what they expect are the criteria for the best quality cancer care. So it's setting the standard which we would hope can be used for those who are commissioning cancer care can adhere to. And in my travels around Europe, there's no doubt that there are certain countries that cannot for the reasons of their own health economies and the lack of investment in their healthcare systems. And I think it's trying to set those sorts of things that give us standards. Audit is one of those things we pay a lip service to, but it does take an awful lot of hard work to get an audit up and running. It was set up in the UK in 2008 with nationally funded government-centred money. The Dutch have done it in a slightly different way, but these are the 2 biggest national audits. There are others, but not quite as comprehensive necessarily. The UK audit was intending to look at the quality of care, both in terms of the way in which patients undergo their assessment, working out the type of treatment necessary, and to look at the outcomes. It's produced a report on an annual basis, and the 2017 report, published just before Christmas, data on routes to diagnosis. 18% of esophageal cancers in the UK present as emergencies. 30% of gastric cancers present as emergencies. Something's not quite right there. The way in which we should do staging. And I do have a problem with the blanket bomb of doing every single investigation under the sun to stage each and every patient. I think we have to be better and more selective. Sorting out the treatment, sorting out the best possible surgery, we've talked about a bit, and the use of palliative radiation and longer-term end-of-life care. We've also looked at high-grade dysplasia because that's an area of interest. And we've got quite a lot of data. It's quite reliable because the surgeons have got better at being prepared to record it. And as you can see there, despite best attempts over the last 20 years, only 38% of cancers are actually presenting with disease that can be radically treated. And in fact, it's only about 22% get an operation because of the way in which they have their comorbidity, etc. The mortality from esophagectomy and gastrectomy has significantly improved. There's no doubt about that. And we talked a bit about squamous cell cancer. But I do think, as I said earlier, the whole patient journey has to be taken into consideration. And patients who die from this disease are far better off at home, but only a third manage that. This is the comparative data that's just been written up, which shows that what's happened over the last 10, 15 years. As you can see, there's been a significant reduction in the number of centres. The annual volume in those centres has gone up. And there's been an improvement in 30, 90, and 1-year survival. So something's happening. Interestingly, from the Duca, this is a paper from the Duca study, which is showing that the LP is the low number providers and the high P is the high number providers, showing the effect that in the high providers, they will adopt perioperative therapy. They're better at recruiting into clinical trials, but 26% isn't very high. And they don't have the grade 3 toxicity. So therefore, a centralization effect is there. But you've got to be very, very, very careful because politicians get hold of this. That gentleman was the chief medical officer, the medical director for the NHS, who in 2013 expected transparency and for all of our data from that audit to be published. And this nice chap is the Secretary of State, who most junior doctors would hang tomorrow without second thought because of the industrial action last year. But he insisted that we should publish all of our data. That's mine. You can look me up online. And the green dots are the operative mortality from my own practice. And this is what's happening when the politicians get hold of this sort of information to show that the service should achieve good results. But my colleagues, when this first came out, were extremely disturbed to have this sort of data in the public domain. And the worry was that the way the data was put together wasn't designed for this sort of purpose. It started, as I say, about 4 or 5 years ago. People have now got used to it. We're easy in surgery because we're a metric that can be measured. Neutropenic sepsis after chemotherapy. Deaths in hospital within 6 months of chemotherapy. Interesting data that perhaps should be shared, particularly if you're on the receiving end as the patient. But I think back to my beginning point that this is about what we would expect as the patient. Jane Blaseby looked at this as the core information that both professionals would expect to be recorded and what patients would be expected. We've heard a lot about anastomotic leak. Yes, we don't want to have patients sustaining unpleasant outcomes from their surgery. We look about risks around comorbidity and recovery because that's the sort of things we're measured with. It's a patient. Am I going to get it back? Will I live? What happens if you can't get it out? What's my quality of life going to be like? Can I go to a restaurant and eat with the family? And it's this sort of thing that I think we've really got to get to grips with. That the patient perception of what's going on to them with this very, very major condition, not only in terms of what you do from the medical and clinical oncology point of view, but the radical surgery that we do. And yes, we're getting a little bit better, the mortality is better, but to recover from a thoracotomy, having an abdominal procedure, does take it out of the patients, particularly if you're going to threaten them with more chemotherapy afterwards. And I think this is something that in the last few years, I think we've got more to contribute because we are certainly getting patients to live longer. The data from we've got some data from the last 15 years at the Royal Marsden, and I think it's the same as everybody else's. There is an improvement. There's no doubt. We're getting upwards almost 50% 5-year survival for those undergoing radical treatment. So patients are living longer. They're living with the effects of treatment, both surgery and oncologically. And I think we've got to get this right for the patient's benefit. So we need to set standards, yes. We need to have everybody engaged and working in multidisciplinary teams and being prepared to be honest and transparent in reporting their outcomes. And we have to have patient involvement. It can be a challenge to do that. That essential criteria paper did require a lot of patient involvement, and this is where I think the direction of travel is so important. And it requires very careful collaboration across all disciplines to get the best for our patients. Thank you very much.